Uh, Today's topic of discussion is operative delivery. Operative delivery, it is a method which is used to expedite the delivery by whatever possible means. It can be done both vaginally, when it is known as the instrumental vaginal delivery, which can be in the form of vacuum or it can be in the form of the forceps. And as we all know that if it is done through the abdominal route, then the only option is the cesarean section. This is the delivery of the baby through the abdominal route, and it is called cesarean section if it is done after the period of viability, and if it is done before the period of viability, we call it as the hysterectomy. As I told that if the delivery is expedited by the vaginal route, it is of two types. Either it is the vacuum vaginal delivery or the ventouse is the other name for it. In this, what we do, we apply a cup-shaped structure to the fetal scalp to deliver the baby through the birth canal. And the other is the forceps delivery, in which metallic spoon-like structures they are applied on either side of the fetal skull to expedite the labor process. Now we will take both of these operative vaginal delivery, that is the forceps and the vacuum, one by one. Collectively, what are the indications of the operative vaginal delivery? We do operative vaginal delivery for both the fetal reasons as well as the maternal reasons. The indications are common for both the forceps as well as the vacuum. But the only difference is that the forceps, they are more easily applied and they are quickly applied. The time required to expedite the delivery by forceps is lesser as compared to the vacuum because it needs some time to create the negative pressure by the suction machine. But ultimately, it is the operator's choice and also the operator's skills in whatever he feels more easier and more feasible to conduct the process to expedite the delivery. So it is ultimately the experience, the skill, and the expertise and the choice of the operator, whatever he chooses. The fetal indications are either the malpositioning with relative to dystocia, that is, it can be an occipito-posterior position or it can be an occipito-transverse position. And second is the fetal compromise, that is, whenever you come across a case of fetal distress, then you can expedite the delivery with the help of the instruments. The maternal indications, they are mostly done when the mother is exhausted to shorten the second stage of the labor, and also the second stage of the labor is shortened in cases where the mother is suffering from the medical conditions because you don't want to put extra burden on the maternal heart or on her muscles so that she is not exhausted and her condition is not compromised. And regarding the cardiac diseases, it includes all the class 3 and class 4 uh, NHYA classified cardiac diseases because it will put extra burden on the maternal heart and she will be compromised. Any cases of hypertensive crisis, especially when it is complicated with the intrauterine growth restriction of the baby, myasthenia gravis, spinal cord injury, especially when it is complicated with autonomic dysreflexia because a prolonged second stage or extra pushing, it can lead to the maternal complications. Then the proliferative retinopathy because it is if the patient pushes for a longer time, so there is a risk of retinal hemorrhage. And then finally, if the nulliparous woman, if she is without the effect of regional analgesia, the labor should not exceed 2 hours, and with regional analgesia, it should not exceed for the 3 hours for the second stage. And for the multiparous patient, the second stage without an regional analgesia, it should not be more than 1 hour, and with epidural, it should not be more than 2 hours. So these are a few maternal and the fetal reasons for conducting the operative vaginal delivery. Now here the picture is showing the forceps. So first we will take the forceps delivery. Here you can see the obstetric forceps. The obstetric forceps, basically these are the metallic spoon-shaped structures and two mesh parts that articulate or lock together at the articulation, which we call as the lock. And it has got certain parts as it is obvious in the picture. That is, you can see that with the help of the pointer, I can explain that this is the handle, which is held in the hands for the proper grip. Then there is an articulation for the right and left blade, which is known as the lock. Then in between the handle and the actual blades, there is a structure, which is known as the shank, and the length of the forceps, it usually varies with the length of the shank. And then from the shank starts the blades, which are applied on the right and left side of the fetal head, and it has got a cephalic curve, which is in proximity with the fetal head, and a pelvic curve, which is in proximity with the maternal pelvis. There you can see the fenestrations in the blades. These fenestrations basically serve the purpose that it makes the instruments more handy, more lighter, and more convenient for application with less trauma to the sides of the fetal head. Now the forceps, they are classified in a number of ways. The first classification is according to the station of the presenting part. As you must be knowing from your basics that the station of the presenting part, it is done on the basis of the level of the ischial spines. At the level of the ischial spines, we take the 0 station, and 1 centimeter above it we take as a negative -1, -2 and -3, and below the level of the ischial spines 1 centimeter is +1, +2 and +3, and that is the introitus. The outlet forceps, they are simply the lift out forceps, and you just has to ease out the delivery. And the fetal scalp, it is visible at the introitus without parting the labia. The low forceps, they are, the fetal head is 2 centimeter below the level of the ischial spines, that is +2, but it has not reached the pelvic floor. The mid cavity is a little high. It is applied at or a little below the level of the ischial spines, and you should be very cautious. The head should not be more than 1/5 palpable per abdomen. The high forceps are those which are now obsolete, in which the head is more than 1/5 palpable per abdomen, and because of the risk of maternal and the fetal trauma, these high forceps now they have been abandoned and they are not used now. The other classification is on the type of the forceps and whether the forceps they are doing the rotation or they are not doing the rotation. Because one purpose of the instrumental delivery is to do the traction as well as to the rotation. The vacuum, it has the advantage that it causes auto rotation plus traction at the same time. But with regard to the forceps, we have to differentiate, or we have to choose whether we need to the fetal head to be rotated or we just need only the traction. If we just need only the traction, then we will choose the non-rotational forceps, which you can see in the figure. There are a number of them: the Tucker-McLean, Simpson, Elliott. Here you can see the anteroposterior view, and here you can see the side view of the forceps. Then are the rotational forceps, which are the keyline forceps, and these are, you can see that because they are applied a little higher at the level of the ischial spines, and they are long with longer shanks, and they differentiate from the other non-rotational forceps in this sense that the lock you can see here is the sliding lock, and here you can see small knobs. These knobs you have to take care that when you are applying these forceps, this knob should always face towards the occiput. So when you do the rotation, if it is in an occipital transverse position, the knob they should always face the occiput so that you can do the rotation clockwise or anti-clockwise depending upon the situation. Now, what are the prerequisites of the operative vaginal delivery? Mostly what we are going to discuss regarding the prerequisites, they are the same for both the types of instruments, that is the forceps as well as the vacuum. And there are a little differences which I will explain as we go along. Now, because these prerequisites, they have been made easier to remember with the help of a mnemonic. There are different types of mnemonics which are being used in science, and in obstetrics, the similar rule applies. We can go for, if you're doing the forceps, you can take the same mnemonic. Some would like it easier, but for me, I mostly follow this ABCD mnemonic because it gives me more ease, and also I have felt that nothing is left out. So from the way it's A, it means that you have to address the patient. Address means that you will tell the patient about her situation, what is happening, why you are applying forceps, what is the condition of the fetus, what is her condition, why does she need the forceps, what will be the procedure, what complications she can foresee, and what will be the advantage that is to have a healthy baby. Because the ultimate aim of having a labor is to have a healthy mother and a healthy baby. And we also, after addressing and taking the consent, regarding the consent, if you are performing the forceps delivery in the labor room, it is always a verbal consent. But if you are doing the same procedure in the theater, then it should be a written consent, because in that case, you might need to go for the cesarean section, because in the operating room or the operation theater, those instrumental deliveries are conducted which need rotation and which head is a little higher up, and the labor, it is complicated by the formation of the caput, molding, and there are chances that the delivery might fail and you have to recourse to the cesarean section. So that's the reason the written consent is taken in those cases where you have to go for the operative delivery in the theater. Then analgesia. It is very important because the patient is very anxious, and also it's quite painful. So you should go for the analgesia. You can give the patient all types of analgesia, starting from the inhalational, opioids, and if the patient, if you have facility of epidural, if the patient is already under the effect of epidural, that can continue. Or you can also give a local perineal block and even the pudendal, because that will ease out the process of conducting the forceps delivery. Then for the B, the bladder should always be empty, because we all know that if the bladder is full, the head will not come down. And secondly, if the bladder is full, then there are increased risk of chances of the trauma to the patient. And if the patient has been already catheterized for some reasons, then you should always deflate the bulb of the Foley's catheter, because that further adds to the trauma. The cervix, that should always be fully dilated, and the membrane should be ruptured, because only then you will be able to apply the forceps. In an undilated cervix, you cannot do the instrumental delivery. The only exception to undilated cervix, which is for the postgraduates, that you can apply a vacuum in cases of cord prolapse in which the fetal heart is compromised with CTG, which is non-reassuring, and if the head is quite down and the cervix is 9 centimeter dilated, then only in that exception you can go for the vacuum delivery. But this is not for the scope of the undergraduate, so it's better you don't mention it. for your perspective, the cervix should always be fully dilated to conduct a instrumental delivery. Then determine the position of the head. How will you determine the position of the head? It is by abdominal examination first and then vaginal, because abdominal examination, preferably no fifth of the head should be palpable by abdomen. But and also the abdominal is more important, because if there is caput formation, then in that case from the vaginal examination you will not be able to judge what is the station of the presenting part in relationship to the fetal scalp. So that can always mislead you. So that's why both abdominal as well as the pelvic examination are very important to determine the position of the head. And secondly, the pelvic vaginal examination tells you what is the attitude and also the position of the presenting part from the sutures. That is the important is the sagittal suture and the position of the occiput and the sinciput. And that will help you to tell that whether to complete this delivery process you need auto rotation. So then you can alter your choice, that you will choose the instrument which can give you auto rotation at the same time the traction. So the determination of the presenting part with the position is very important. Next comes E. E stands for the equipment. In cases of the vacuum forceps delivery, the equipment is the two members of a single pair of the forceps. So you have to assemble those forceps in a similar way as you do it in the as you apply in the patient, and you will assemble them in front of the patient, mimicking the same technique as it is done to conduct the delivery. And you have to make sure that they belong to a similar pair and they are articulating without any difficulty. And then also other things you have to check, that you have to check the equipment for the resuscitation of the patient, because the forceps deliveries or the operative vaginal deliveries, they are a little tricky, and one of the indication is a fetal compromise. So the equipment for the resuscitation as well as the equipment for the episiotomy should always be there, because you might need to perform the episiotomy to ease out the resistance of the soft tissues or to prevent the tear. The further position assessment of the fetal head is done by the palpation of the fontanelle along with the sagittal suture, because that gives you an idea about whether the head is occipital anterior or posterior, because the anterior fontanelle is diamond shape and the posterior fontanelle is triangular. So that gives you a fair idea about the position of the fetal head in the maternal pelvis. Now comes that how you will apply the forceps. Hold the, it is always the left blade which is applied first. So, and the left blade is applied, it is held in your left hand and it is applied on the left side of the maternal pelvis. Hold the left hand forceps blade in your left hand using a pencil grip, aligning the handle with the right inguinal ligament. Okay, and then introduce your right hand into the vagina and feel the blade around the fetal head, guiding its application with your index finger and thumb. Repeat the procedure with the right blade, mirroring these actions, then locking the blades in the midline. The handles should be lying in a near horizontal plane. Check that the sagittal suture can be felt in the midline, because this will produce less trauma, and that no more than a fingertip can pass through each of the blade's fenestration. This is very important, because if more than or less than a fingertip is passing through that fenestration, it means your application is not correct and it will lead to more trauma to the fetal head. Now, after you are fully sure that the forceps they have been applied correctly, then you wait for the uterine contractions. And during that time, what you do, another thing which is known as the Paget's maneuver. What specifically involves a Paget's maneuver that apply while the forceps have been assembled on each side of the fetal head, apply horizontal traction to the forceps with your right hand and vertical pressure with the left. This is the Paget's maneuver, and it is basically designed to bring the fetal skull below the pubic arch. I know it's a little difficult for you to understand during this stage, but if you listen to this audio a number of times along with these pictures, then you will be having a fair idea. And if still you are unable to understand it, then you can come in your maternity batches in the labor room and we can explain you very well. Now, how the gentle traction will be applied. The gentle traction, it is always applied in line with the pelvis. As we all know that the pelvis is a curve in which it is first downwards, then downwards and forwards, and finally forwards and upwards, just like a J. So your gentle traction should be along the arc of the pelvis, which is roughly like a J, and the traction they should be accompanying along with the uterine contractions, and you should not, it should be always be a single-handed traction. You should not use extra body force with your feet resting against the delivery table, because then the force will be out of proportion and it is liable to damage the fetal head, or it is going to cause very bad tears in the perineum. Secondly, this gentle traction should always be accompanied by the uterine contractions, because, and you will at this point in time, you will tell the mother that we will be working in cooperation. You will be helping me and I will be helping you to ease out this delivery. So, and keep on talking to the mother so that it is not a stressful situation for her. As the perineum stretches, perform a right mediolateral episiotomy if required. It's optional because I is for incision. G will discard the gentle traction, and the next in the line is mnemonic is the H. H is to halt. Halt means that you should know when you have to stop, because this is very, very important. Because sometimes enthusiastically, it should never be in your mind that you have to deliver by this baby by hook or crook vaginally. It's always like a smooth driving. You should know when to stop and when to start. Because halt means that with three tractions, you should with three tractions, you should be able to deliver the baby. And these tractions should be in collaboration with the maternal contractions, uterine contractions. If you are unable to deliver the baby in three contractions or three pulls, then you should halt. If you are unable to complete the delivery process within 15 to 20 minutes, again you should halt. If you see that there is no descent in the head, again you should halt. This is very, very important for the safety of the mother as well as for the baby's safety, and in return for your own safety as well. Because if any of the maternal or the fetal complications occur, you will be the one who will be answerable, nobody else. So mother and the baby, they are very important, but your own neck is also very, very important, especially in this era of the legal implications. Then in CN, we already discussed that episiotomy is optional and only when there is a threat to tear, or if there is a very rigid perineum, or you think that this soft tissue resistance is too much to allow the delivery to be conducted smoothly, because a clean incision is much better than a very bad tear. You don't know where it goes. Then finally, when you have to remove the forceps, this is also a very important part, and the forceps, they should all be removed when the chin or the jaw of the baby is visible. You then you remove the forceps one by one, and as you inserted the left one, so it will be removed later. The right will be removed first and followed by the left one. So it is opposite to the insertion, where the left is inserted first and the left is removed second at the end. So this is the technique which I have explained mostly when the head is in the occipito-anterior position. If the head is in the direct occipito-posterior position, as we all know, in occipito-anterior position, the baby head is born by extension, while in occipito-posterior position, direct, the baby is born by flexion. Now, what are the complications of the forceps delivery? There are both fetal complications and the maternal complications. In the fetal complications, there can be brachial plexus injury, and also there can be, because of forceps, they are applied on the side of the skull. So with the lock or the end of the handles, if extra force is there, there can be damage to the facial nerve, but that is mostly temporary. Then there can be fracture of the skull in very severe cases. There can be trauma to the face, scalp, or there can be shoulder dystocia. The shoulder dystocia basically is not a complication. What I would like to add in the mnemonics, that in D also stand for dystocia, the mnemonics. That is, in any case of the instrumental delivery, you should always anticipate the dystocia and you should be fully prepared for that. And you should also be able to diagnose from the signs when the shoulder dystocia is occurring. That is the turtling sign. And the maternal complications are, there can be trauma to the vagina, there can be trauma to the cervix, especially if you have applied the forceps or the instrument vacuum when it is undilated. That will lead to the trauma to the cervix, which can even extend into the uterus, because it's the forceps, they are applied after a long labor, especially in the prolonged second stage. So there can be hemorrhage either because of the trauma as well as the uterine atony. And finally, the infection. So always aseptic technique should be there. And one thing which has not been mentioned in this slide is the problems with the urinary and bowels. That is, the patient, because it is quite a traumatic experience, so the patient can have urinary retention either because of the trauma, or if the mother is having epidural, then if the catheter it is removed earlier, then because of desensitization there can be a retention of the urine. So you should always ask the mother whether before discharge whether she is normally passing urine or not. And if there is any problem, you should always measure the residual volume. It should not be more than, in this normally it is less than 50, but in this situation, if it is more than 150, always think of catheterizing the patient. And regarding the bowels, it can be the patient should regularly move her bowels, because even the constipation or because of the pain, if the patient is not properly emptying her bowels, it can lead to urinary retention. And also, after the delivery, you should always check the perineum for any tears, and always exclude the 3rd or the 4th degree perineal tear, or also the buttonhole tear in the vagina, because they can be missed if you are not careful enough. After this forceps delivery, what you should do, that you should immediately hand over the baby to the pediatrician, and cord paired samples for blood gases should be done. All the things should be documented, and you should debrief the patient that what happened, why this happened, any complications, and what to expect in future, because in it, and tell her, because some of the patients, they undergo in a very bad post-traumatic stress disorder because of the traumatic experience, and they are always afraid of becoming pregnant in the future. So always counsel them that 80% of the cases, the next delivery is going to be without any complication, and it will be very simple, very natural, without the need of any instruments. Now comes the other entity, the vacuum or the ventouse delivery. For this, I would like to tell that the vacuums are also of different types. They are made of the plastic cups. They are made of the elastic material or the rubber because they cause less trauma. In the past, only metallic cups were used or available, and nowadays the metallic cups, they have been reserved only for those deliveries in which there is a fetal scalp, because these soft rubber cups or of the elastic material, they have this problem that they can easily be popped off, and you might end up in not achieving a vaginal delivery, and multiple popping off further increases the risk of trauma to the fetal scalp. And in the picture, you would have seen another small uh, cup which is attached with another gadget, the handle and everything, and that is the kiwi cup. It is a simple lift out vacuum delivery similar to the outlet forceps delivery, in which again it should be applied when the scalp is visible without parting the labia. Now for the vacuum delivery, again, it's just a revision that you go through all that mnemonic, that is address the patient, ask for help, adequate analgesia, and consent. The bladder should be empty except for the one thing which I already told, that if the baby is compromised with pathological CTG, with a cord prolapse and the head is low down, where you can, if with 9 centimeter dilatation, you can go for the vacuum delivery. The cervix should be completely dilated to avoid the trauma, and you should determine the position of the fetal head, and you should be prepared for the shoulder dystocia. Equipment should be ready, that is the vacuum. You should check this equipment. Unlike forceps, you should, because it's a big assembly, you should check the vacuum, the tubing, and to the electric machine which is building up the negative pressure to see whether it is properly working or not. And you should check this assembly plus the working condition by applying the vacuum to the hollow of your palm of a gloved hand to see whether the negative suction is being made or not, so that you don't fail when you are applying it actually on the fetal head. Then also there, apart from the electric negative pressure suction, there are this kiwi cup, it is also manually operated, and there are also other cups which are operated by the manual machines. And this solves the problem in underdeveloped countries, where if the electricity is not available, then the electric sucker machines will not work. Then F is to place the cup in the proper position, and here it is important for the flexion point, because if you don't apply the cup on the flexion point, it will not lead to the flexion of the head. And as we know that if the flexion, baby is in flexed attitude, only then the suitable diameters will come into play, will be engaged, and it will facilitate the delivery. And where is the flexion point? It is 3 centimeters anterior to the posterior fontanelle and 6 centimeters behind the posterior anterior fontanelle. So this is the point where we will apply this cup, And when you apply this cup, it will cause the flexion, and it will help in the rotation as well as the descent of the fetal head. Then G is for the gentle traction. This follows the pelvic curve, and again we have to work in cooperation with the mother and along with the uterine contractions, because both these forces, our gentle traction and the maternal push with the contraction, they will add together to produce the effective force required for the delivery of the baby. Then H again is halt the traction between contractions. That is, you should not pull when there is no contraction. Then halt the procedure if the cup disengages for 3 times. Halt if there is no progress, which is evident by the descent of the fetal head in 3 pulls. And halt the procedure if you are not successful after 20 minutes. And again, you should be self-motivated for this halt to avoid any trauma to the baby, mother, and ultimately yourself. Avoid pivoting and rocking movements, because they will just cause increased trauma to the fetal head. Again, I for incision evaluate for episiotomy at the time of crowning. J, when you have to remove the cup, when the jaw is visible, when the chin is visible, that is the time when you will remove the cup by switching off your machine, and also by a knob which is present on the side of the cup that will release the pressure and the cup will be disentangled. The technique we have already discussed, but one thing which I did not tell is that about the pressure 0.6 to 0.8 kilogram per centimeter square should be the pressure when the cup is applied. And this increase in the pressure with a negative suction built in by the electric sucker should be gradual. It should not be all of a sudden, to avoid damage to the fetal scalp because of that sudden increase in the negative pressure. And the rise should be at the rate of 0.2 kg per centimeter square, up to maximum of 0.8 kilogram per centimeter square. Now again, these are the steps. You can see that important thing, that when you are applying the cup to the flexion point, you should always check that none of the maternal tissue is entrapped between the fetal scalp and the cup, rim of the cup, because otherwise there will be trauma to the maternal tissues. Then again, you can see how the traction is being applied and the baby is moving along the arc, first downwards, forwards, and finally upwards, and then crowning. And then you can see when the jaw is visible, the cup has been removed. Now the complications we already discussed in the forceps, they are almost the same, but in cases of the maternal complications, they are more with forceps, 3rd degree and 4th degree perineal especially, and extensive vaginal and vulval tears, and PPH is also more with forceps. So regarding the mother, vacuum is a little safer, and the neonatal complications are a little more with vacuum. It can cause the subgaleal hemorrhage, which is below the aponeurosis. It is more with vacuum. Intracranial hemorrhage is also more with vacuum, and injury of the 6th and 7th cranial nerves leading to Erb's palsy, it is mixed with both. And this basically occurs when you are delivering the baby's head after disentangling the instrument, and if you are applying too much of the lateral traction for the delivery of the baby, then it can lead to this thing. Then cervical spine injury, it is more with rotational forceps. Ordinary forceps or with vacuum, it is hardly to see. Then here in the diagram, you can see these are the different layers of the scalp. This is the scalp, then this is the connective tissue, then this is the aponeurotic layer, and this is the again the connective tissue, then this is the periosteum. And here capered succedaneum, which occurs because of the suction, negative suction of the scalp into the cup. And this is a normal finding. It usually you have to tell the mother after, if it is there, you will counsel her that it will disappear within 2 to 3 days. And then this is the kepal hematoma, which is below the aponeurosis. This takes a little time, maybe 1 to 2 weeks. Then there is the different layer coverings of the brain, and then there can be internal hemorrhage, retinal hemorrhage, or subarachnoid hemorrhage. And this is more with vacuum delivery, especially if the cup pops up a number of times, or if you are applying too much force out of proportion, because the force should always be with a single-handed dominant hand. Now the comparison, I think I have already explained, but just a quick revision, that forceps are less likely to cause neonatal morbidity like kepal hematoma, subgaleal, or retinal hemorrhage, and it is more with cases of vacuum. Forceps, they are more likely to result in maternal soft tissue injury, which is less with for vacuum. And the forceps, they are more likely to result in successful vaginal delivery, especially in the cases of caput formation. And it is less likely to be achievable if the caput is there with vacuum, because a vacuum mostly pops up in such cases. And regarding analgesia, the forceps, they are a little more painful, but the vacuum requires less use of regional analgesia. And there is less serious maternal injury with vacuum. So forceps are suitable for assisted vaginal deliveries at less than 36 weeks of gestation. But the vacuum should not be applied to the preterm babies because of the increased risk of intracranial hemorrhages. Now we are over with the operative vaginal delivery. The operative abdominal delivery cesarean section. That is a very big topic. It just needs a full explanation. So we will take it separately in another presentation. The presentation, it will be totally dedicated for the cesarean sections, its types, methods, and complications. But overall, cesarean section, as I already told, that it is the delivery of the baby through the abdominal route after the period of viability. And if the same procedure done before the period of viability is hysterectomy, and WHO recommends an overall incidence of 15 to 20%. Thank you. I hope I'm clear. Any queries? Because the forceps, these are all imaginary things. Because the pelvis, what happens inside the pelvis to the baby or to the mother, these are all imaginary things. And I think it's very difficult to explain them like this. There are, as with the increased IT involvement or the social media, you can see all these forceps deliveries as well as a vacuum delivery on a YouTube channel, and that will give you a very good idea. And you can also come in the labor room and we can explain you, and we can make to visualize these deliveries in the labor room, and that will give you a very fair idea how it happens. Thank you.